Dr. George, can you let me know what you think about breast cancer screening, what it involves?
Breast cancer screening involves both a self exam, a clinical exam, and an actual imaging exam. So it's like a three-phase process. I start by talking about the self exam, knowing your breasts. A lot of times, patients will say to me, my breast is lumpy. I don't know what to feel for. And I tell them, you don't feel for anything. You feel just for the natural texture of your breast, get familiar with your breast, know where the lumps are. So if a couple months down the road, a year later on, you feel something, you'll be like, wait a minute, this was not there before. And that's what you're going to call your doctor and follow up on. So that's what the self exam, breast exam is for. You're not an expert. You're not going to know when something is a cancer, but you're going to know when something is new, when something is different. And that's what a self breast exam for. The clinical breast exam is when you can go to the gynecologist or you can go to a specialist, your primary care provider, and they do a clinical breast exam. They are specialized, they know what they're looking for. They would also examine you. And a lot of times they may find changes in your breast and they may refer you for a mammogram or ultrasound to further determine what that change may be. And then we have the screening regular mammogram, where on average there have been in the past 3, 4 years a lot of controversy with what is the age for screening. The United States Task Force came out with a recommendation stating that it should start at age 50 and continue every 2 years. Where we in clinical practice at Johns Hopkins, if that was really the age that screening should be, a lot of women would have been dead between the age of 40 to 49 because we diagnose a lot of patients between 40 to 49 that was only detected by a screening mammogram. So that's the reason why we still recommend that screening start at age 40. No provider wants to tell a patient, don't do it until they are 50 years old. So we still maintain the guideline, the previous recommendation that screening should start at age 40. And if it is that you have a first degree relative, such as a mother or a sister that had breast cancer under the age of 50, you will start your screening 10 years younger than that person. So if your mother had breast cancer at 45, you would start your screening mammogram at age 35. Also, we also have younger women having changes in their breasts. And because of that, there is I was talking to one of our senior radiologists recently, and he said because the breast tissue in young women, they try not to give mammogram at such an early age because the exposure to radiation in underdeveloped breasts can really cause things to change in the breast. So sometimes you may be offered an ultrasound as a screening tool in a younger patient population. Uh, Also, for individuals with high risk, the MRI, of course, is going to be a tool that will be used as a screening mechanism for them, the breast MRI. So that's typically the three-tier format of screenings for breast cancer.
So, what I'm hearing is that there are many ways to screen,
Mhm.
and that really a patient should discuss what's best for their specific case with their provider.
Yes, they should. They should. And I think with the recommendation, and I think that's previously there was the standard of screening mammogram at age 40. And I believe when the United States Task Force made the recommendation at age 50 and they should screen every 2 years, it was so confusing in the community because what we see is that with triple negative disease and populations where that they are high risk, we are not too sure that that data was transparent with those populations. You know, when you look at data across the country, But if you look at a pocket of data from Washington, D.C. and Baltimore City, is it very reflective of the data across the country? So you always have to really, as a provider seeing your patients, you look at recommendations, but again, you got to know where you live, what is happening in your community, who is your patients and who is at risk. And you really got to advocate for your patients, because a lot of times that's what we do. And we want to make sure that we reduce the risk as much as possible and want to catch these cancers early, because that is how we are able to cure the breast cancers, is by being able to screen and then identify them at the earliest stages.